Well, now it's my distinct pleasure and honor to introduce our visiting professor, our guest for our symposium and for our celebration, Professor Irene Higginson. Irene Higginson is, I gotta read this, an officer of the Most Excellent Order of the British Empire. That's huge. That's a big, we don't have anything like that. That's awesome. I had to look it up, but that's really fabulous. But more importantly, she is the Executive Dean of the Faculty of Nursing, Midwifery, and Palliative Care, and leads the faculty's academic and strategic direction at King's College, London. Irene is Professor of Palliative Care and Policy. She's the founding professor of the Cicely Saunders Institute at King's College, an honorary consultant in palliative medicine, and she is the scientific director for the Cicely Saunders International. She's dual trained in palliative medicine and public health medicine. She's an internationally recognized researcher and really one of the leading lights in our field in research and in thought leadership and in mentorship and really in promoting and advancing the field of palliative medicine. I've had the pleasure to know Irene for many years now and to have had the opportunity to collaborate and research and to work together, and it's really been just an absolute joy. Her research and education are in the top 1% of highly cited academics. Her research, it really spans our entire field, and it's incredibly impressive. Better ways to measure outcomes and quality of life, to evaluate palliative care, especially new services and interventions, the epidemiology of palliative care, the effectiveness of palliative care, psychosocial care, symptom assessment, breathlessness, cachexia, anorexia, and multimorbidity. Just an incredible body of work. This blew me away when I read it, that Irene has over 700 peer-reviewed publications, which is crazy. I told Irene I'd need 4 lifetimes to achieve that. That's really tremendous, and I think really just reflects not only your work, Irene, but just your incredible mentorship and research mentorship of people and the collaborations that you've developed. When we were thinking of the celebration of 25 years in the symposium, I immediately thought how wonderful it would be to have you come and join us, Irene, because of your leadership and your vision and just the wonderful connection within our field. And we're delighted to have you here. We had a great day together yesterday on rounds and in our journal club and our works in progress, and you were generous to meet with so many of the faculty. And so thank you for joining us. Thank you for your incredible body of work. And we're really honored to have you here and excited to hear about your presentation, The Role of Palliative Care in Meeting the Challenges of Healthcare Around the World. Thank you, Irene.
Steve, thank you very much for that very generous introduction. I'm just looking around for where the main speaker is now. Can I say what a real honor and delight it is to be with you here. It was really wonderful to arrive yesterday. To go on the rounds yesterday. I think I arrived on Tuesday night, so I'm just slightly vaguely jet-lagged, but recovering. But it's such a pleasure to be here and such an honor on this. So I want to start with a few congratulations and a sort of thank you to build on what Steve said for all those who made it possible. It's also very nice to be here. Yesterday, this is London, because there was a major thunderstorm over London, and that's the lightning of it. I don't think this is not my photo. I don't think this is San Francisco yesterday, but it's that sort of nice weather in the spring. So it's nice to be there. But I also kind of think that the journey in palliative care, in a way, this extreme of the thunderstorm and the blue sky is a bit of a metaphor of the journeys that we make in palliative care. You get really difficult, dark, stormy, rocky, lightning, thunder times, and you also get bright days that make it better. And in a way, I think it's been my privilege to work with you, Steve, other colleagues of yours around the world, and others around this room over the years to achieve what we've done in palliative care. And I think, I'd pay a particular tribute to all of those in this room who have made this possible or are continuing to make it possible. And I will do a particular shout out to the patients and families who are very generous in their time, not only in advising on what happens, but also in engaging in the different activities. I think the huge dedication of team members, staff from all different professions, the volunteers, and also the people who support palliative care, because I think without the philanthropic support that palliative care has had from very generous donors, it wouldn't be where it is today. And I know we've benefited from that in the UK, but I think that is really important. So a big round of applause to all the donors who've really helped make palliative care possible. So what I'm going to talk about today is a little bit about a future look. Steve and I were discussing this, and I'm going to talk a bit about how health and social care is changing, and a bit about the way in which population demography and illness is changing. Because in a way, I think that one of the reasons why my research has moved in the ways that it has, and it has been quite broad, is that I've always tried to adjust my research to the needs of the field at the time. As well as following things that inspired me. And I want to have a reflection around what's that going to mean for how we as palliative care should respond, the sort of solutions that palliative care has, and then I hope maybe some discussion and some questions throughout the day and in the sessions that we've got on the way forward. But before I get into the detail of the sort of numbers and the issues for the future, I just want to pull us back for a moment onto the issue of why we're all here and what we do. So this is some data from an evaluation of an integrated palliative care breathlessness support service that we developed. And I just want to remind us that even though we might look at data for lots of people, we also have to think really close down that in the end what we do is we care for individuals in the context of their family and their situation. And in a way, because of my dual, which Steve mentioned, my dual palliative care and public health, I kind of can take this broad, what's the population doing, but what I really also care about is the palliative care, what's happening for the individual. And I think those dual perspectives are important. I want to bring us down to the individual. So this is some data. I'll show you the trial results later, but I wanted to pull this out first. So this was a lady with respiratory failure, chronic obstructive pulmonary disease. Her breathlessness was getting worse and worse, and she had other symptoms. And when she first came to the service, which was being evaluated in a trial, and she said, I feel worthless, I'm a nobody, I can't do anything around the house, I can't do any housework, I can't contribute, and everything. I'm a nobody, she said. I am worthless, I might as well die, is kind of what she was saying. And interestingly, at the end of the service, she talked about being able to cope. And one of the things I really loved about what she said is she had a new perspective on herself. She also talked about how the service had helped her family and her husband, and he'd been able to talk about things. And although it wasn't time yet for him to have to do much more because she was feeling a bit better, she actually knew then that there was something there that would kind of catch him. Other people talked about different things. I've gone out into the garden last Friday for the first time in 6 months. It was fantastic because they liked just going outside. They hadn't been well enough to do that. Or just simple, this is a very British way of saying it, I was thrilled to bits. It sort of means I'm very happy. To be able to get some knowledge on what my complaint was all about. So just the information that helps people comment. And that they're doing something. So often patients are told there's nothing we can do. But actually there's an awful lot that palliative care can do. Or, the knowledge gained is said by somebody as greatly improving my symptom. And in doing so, it's transformed my life. So we have the potential And we should always remember the individual, even within large data sets that we look at. So let us take a step into then the future, okay? So, I mean, we're back in space. There's all sorts of changes in the world around us that are impacting on what we do. And there are people movements like patient empowerment, but there's also technology. You mentioned some of this, the virtual, the wearables, the precision medicine, the kind of 5 Ps of healthcare innovation that are up there on the slide, which includes the idea of personalization in prediction and so on. There's the whole issue of, you know, more or less everything we do and walk around with can become wearables or part of us as we go forward. So all of these will be important for us in palliative care to reflect on how we respond to these types of things. Let's move on as well. You know, there will be wearable devices. There are already wearable devices, virtual consultations, robotic surgery, all the minimally invasive procedures. The 3D simulation for activity and procedures is already with us. Computerized diagnostics, the predictive AI, the virtual, perhaps a step further is going to be the virtual healthcare assistants who get involved, and perhaps bots even as the first line for triage, which I think personally I wouldn't like, but perhaps some, you know, you get it with banks, you get it with everything else. It will probably come, and many people will be used to dealing with that. You know, and the process, in a way, either you have a new virus or my computer does, you know. The whole threats of cybersecurity in some of these things that go across us is worth thinking about. And I think there are some major opportunities for us in this. If you think about the electronic health records, then actually they have the potential to develop early warning systems, decision support systems within them, AI to identify and predict. And actually, we've been doing a lot of work in the UK, doing research behind what's called trusted research networks, is where all the national data is held, and you can log in behind a very secure firewall and understand prediction about patients. And a colleague of mine at King's called Richard Dobson has developed this fantastic system called CogStack, which takes the electronic record data and sort of puts it into a safe haven behind a firewall where you can work with it. And his work allows what he described to me as the Googleization of the clinical record, because the clever thing about it is it can search on structured fields, so, you know, age as a structured field, and unstructured fields, so just open data that the clinicians write. And you can get much cleverer then at developing predictive models. So, you know, colleagues of mine who work in neurology have developed this lovely system for people with epilepsy, where actually they can monitor things at home. They can predict very clearly from that monitoring when somebody might, because of the AI systems that they put in place, when that person might be might fit, and then the day before that happens, they can get them to adjust their meds and predict it and prevent it. So if we can think about how we can use these opportunities for palliative care, we can expand our reach. There are also slightly more challenging things as well. I mean, we've had the global pandemic. I'm going to come back to that. But also, a big feature in our country is the environmental impact of healthcare. And let me remind you that if healthcare were a country, it would be the 5th largest emitting country of greenhouse gases. So actually, in healthcare can make some big changes in how we reuse and use efficiently some of the resources that we have. The bottom graph shows the aging across the world, and I'm going to come back to that in a moment. But what you can see as a world issue is that aging and the number of people over 65 is increasing all across the world. But we also have a shortage of staff across the world. So I don't think it's any better. This was the World Health Organization's State of the World's Nursing Report, which shows that there will be a global, well, there is already a global nursing workforce shortage, which is going to get worse as we go forward. So one of the biggest challenges is how do we respond that? And that shortage is greatest in the low and middle income countries. So what ways can technology, ways of working actually respond to this? And on top of that, there's the escalating need for palliative care. And I'm going to dig into this a little bit more. But on the left-hand side of the graph, you can see the predictions for England and Wales. And on the right-hand side of the graph, you can see the global world predictions. And what you can see is that between now and 2040 or 2060, depending on which data you want to use, palliative care needs or serious health-related suffering, depending on how it's measured, is going to rise substantially. And it's going to rise in all parts of the world, and it's going to rise particularly in low and middle-income countries. So there is a very important responsibility for all of us to try and work together to find how solutions to this. And my vision is that actually palliative care has to be an important part of the solutions. And that's the argument that I'm going to make to you today. This is just some data from Ireland, but I picked it out because there's quite an important development here in Ireland. They use a similar thing, but look here about the deaths from dementia. That is probably one of the areas that is climbing fastest, but the other area that's climbing fastest is multimorbidity. So the aging of the population, which is a jolly good thing, actually. I'm quite happy to be aging. I prefer that just to the complete alternative, just right now. So I'm quite happy to be aging, okay? I'm quite happy that populations are aging. I'm quite happy that my friends are aging, that my family is aging. So aging is a good thing, and most people who are elderly and get older are fit and healthy. But comes with aging and the advances in medicine is the growth in multimorbidity. And comes with that is the differential effect of deprivation, so poverty in particular on this. So what you see on the left-hand side is aging and multimorbidity over time. And on the right-hand side, you see morbidity in people who are deprived in the dark blue circles. And they are much more common across each individual disease than people who are affluent. And aging, multimorbidity is rising in all ages. So this is some slightly old data because nobody's repeated it yet. But it's very interesting. What he shows is that if you compare this period of 6 years, that at every single age group, you can see, if you look at the blue line that runs across, that multimorbidity is higher in the later period at every single age group. So it's not just an issue of aging, it's also an issue of the way in which healthcare is advancing, which is a good thing, but it also brings consequences. And in our patients in palliative care, I think one of the biggest important changes that we see as we move from a service that was very cancer orientated, and cancer was a disease that basically had a very sharp, difficult decline and prognosis. Cancer has now become a fluctuating disease, and most other chronic diseases have become fluctuating. And the smooth trajectories that people used to talk about, I don't believe exist anymore. And even within one condition, many patients have different trajectories. So this is some work that Claudia Bauswein and myself did a while ago. But what you can see is these interesting fluctuant trajectories for everybody, with some people getting worse, some people getting better, a lot of people varying. So that uncertainty and that dealing with fluctuation is going to be important. The other really important thing that I think we need to think about is physical frailty. So this is some really nice data. I've got a particular interest in respiratory diseases. And this is some very nice work on physical frailty and pulmonary rehabilitation. in chronic obstructive pulmonary disease. And you can shift with rehabilitation, so muscle strengthening, not big things. You can shift people from being frail to being pre-frail, and you can shift people from being pre-frail to not frail. So you can shift the curve. And one of the things I think for the future of palliative care, I'm going to challenge you where your physios are, is the integration of allied health professionals such as physiotherapy and occupational therapy, which of course can be aided by nurses and doctors and so on, but actually that engagement is really important for our future palliative care populations. I can see some of you nodding. I know some of you work in neurology. In neurology, that's incredibly important. Some of you work in respiratory diseases. In respiratory diseases, that's very important. There's some work that my colleague Joe Bailey is just completing at the moment, looking at prehabilitation, so before cancer treatment, rehabilitation to do muscle strengthening, and how that helps people in the recovery from the cancer. So these sort of advances are all things that actually we in palliative care can think about. But we have a paradox in how healthcare is developing and evolving. And the paradox is that there's more specialization, and yet there's more multimorbidity. So the risk for a patient nowadays is that you will see 3 different cardiologists, all who deal with a different bit of the heart, 2 different respiratory clinician doctors, and 1 renal doctor, and maybe somebody else. And it becomes a much more fragmented system of healthcare. And I think that there is a question about how that is, and I'm sure you've all seen it in the practice and the clinic, that people who've got different messages from different people, it's very difficult to join this up. And there are challenges to healthcare quality just due to the complexity of complexity in communication. And a lot of these clinicians tend to advise for their own specific condition, but who is overseeing this? Are there ways in which the robotics, AI, and computerized therapies that we talked about earlier could cut some of this out, could make it simpler for people not to have to see so many different people, and core key workers could be helped with this type of information to develop things? And what will we need? How will this happen? Perhaps, as the cartoon seems to suggest, nurses will have a greater role, and the computers will have a greater role, and in the middle, the physicians might have a slightly smaller role. I think the other question in my mind, and if you look at the sort of circular chart, is that I think we're not thinking enough about self-management and family involvement, or maybe healthcare systems aren't. I think we in palliative care do think about it, but how much can patients themselves think about self-management and family involvement, and then extend out to the clinical expertise? So you have this idea of the circles of healthcare coming out, and perhaps that will help us grow community outside of hospital care. And I think one of the challenges that we face in the UK, and I think you probably face here, is these health and social care divide or non-divide and lack of integration. So, as in the UK, the system is that healthcare is free at the point of delivery, at least to the person who gets it, so they don't pay for it as they get it, although everybody pays for healthcare through their taxes. Even people who don't think they pay taxes do pay taxes, because they pay something called value-added tax, which is added on to everything they buy. So unless they don't eat, they pay value-added tax, and I think that's somewhat difficult to survive. So everybody pays for their healthcare service through their taxes in one way or another. It's not true that people don't pay taxes. Everybody pays taxes. But it's free at the point of delivery, but social care in the UK is paid for. And I think that in your insurance systems, you also have divides between health and social care and the way in which things are offered. But one impacts on the other, and I think that can be quite challenging. And then there's an opportunity in the growth in empowerment, which I think we welcome, self-help awareness for some communities. But the resourcing of healthcare is very challenging. It's rising incredibly quickly in the US. I know it's a problem for you here. There are debates about how best to deal with it. I think you have did somebody say you had a presidential election coming up? I seem to have heard something about that. And you know, in the UK, we may have an election at some point because the Parliament has to call it at some point. It's very debatable. There are elections going on at the moment in the UK, so my friend, they're only the mayoral and local elections, but we shall see. So all of the governments are going to be tackled with this big question of the resourcing of health and social care. You know, and is everybody going to have 15 minutes of healthcare coverage, as the slides suggest? And I want to come back into the population aging about where people are cared for. So projecting where people are going to be cared for is much more complicated than predicting numbers. But in some ways, we need to have the services in the right place. We've attempted to do some of this. But this is going to be influenced by previous trends, by availability of services, by incentives that exist, and also by people's preferences. And therefore, where people live and where they die is going to be changed by policy and practice, and improvements are therefore possible. That's the thing that gives me hope in this, is that where people are cared for is amenable to change by what we put in place, if we put the right things in place. And just to remind you that the World Health Organization in 2014, so we're 10 years on from this, and I do wonder what progress we've made a resolution on palliative care to be integrated into healthcare systems. And it said it was an essential healthcare service for people with chronic and life-limiting illness. And all the countries stood up and pronounced this. Everybody stood up and said how they supported this. And yet, across the world, I think in 10 years, we've not seen enough progress. So, to make care better, we need passion, we need the policy, and underpinning that passion and policy, we need to do the right things. And for me, doing the right things means bringing out research and education. We need to teach people about the right things to do, and it's really commendable, all the education that you've been doing, and we need to research to discover things. And what I want to move on to next is how I see research is going to be such an important responsibility for us in the future area of palliative care, because we can develop and improve our services, but it's research from centres such as this which is going to be so important in discovering how to care for more people, how to transform care at scale, which is what we need to be able to do, and then to spread that through education. And I think we need what I call transformative research. And the really exciting thing for me yesterday, spending time with you, is I think you're already on this journey of this transformative research, because the innovations that I heard about yesterday are so exciting. The ideas that people had were really great. So, you know, what are the new ways that we can provide palliative care? Can we make sure they're effective? It's okay to evaluate services as a block, but any service also has to do things. You know, you have treatments that you give, therapies that you advise, ways in which you talk. So you also need to evaluate and try out new individual, what I'm calling therapies, you could call interventions. They're not necessarily medicines or drugs, they can be non-pharmacological as well. But and for medicines, you can, you know, we have a long tradition in palliative care in repurposing therapies, so some of those. And we need to conduct and show people how to conduct research during complexity. We cannot just simply, in a research study, exclude everybody who's complicated. The way that years ago people used to exclude everybody who was a woman because they didn't fit the criteria. We've stopped doing that now, but still we exclude far too often from research studies people who are complicated. And I think this is an important part of our response to the growing costs of healthcare and treatment. And let me show you just a few things that we absolutely know that palliative care can do. So, you know, early palliative care in cancer, yes, it works. You know, we have Cochrane reviews. We don't need to show this again. we know it works. Here's another one on the effect of specialist palliative care on quality of life for people with advanced incurable illness in hospital, hospice, or community settings. Really nice, straightforward, systematic review showing that it works in cancer. Not many studies when this was done in non-cancer. We hope for more. I showed you the quote from the Breathlessness Support Service, but here we are in the actual data from our randomized controlled trial. So early palliative care integrated with respiratory disease, with respiratory services for people with respiratory disease. Most of them had COPD or interstitial lung disease, ILD, had a benefit on the primary outcome, which was quality of life, 16% for palliative care, and they live longer. And I must admit, I did a similar study, so I apologize to the neurologists in the audience. I did a similar study in multiple sclerosis, and there was also it was a very small study, and there was a slight survival difference, and I was feeling a bit naughty at the time. So I showed them the data, and and I said, oh yes, and here's the palliative care group. There was slightly higher deaths, and the non-palliative care group, there were slightly fewer deaths. And they said, oh, yeah, that's it. We know. Palliative care, you kill people. We know that. You kill them. And I said, oh, I'm so sorry. That's the wrong way round. Actually, the palliative care people live longer. They said, and you know what they said? Oh, it's a very small sample. You can't really draw any conclusions. But, I mean, there's lots of other data that's like this. The TEML study. You know, the famous American TEML study also shows this very clearly. Does palliative care people help stay in the community? Yes, it does. This is the Gomez systematic review, Cochrane review, which is just in the process of being updated at the moment. And a colleague working with her who used qualitative methods, something called meta-ethnography for the qualitative people in the room, which is a very interesting technique, tried to look at how it works, because actually it's not enough to know that something works. You also need to have a kind of model or an idea of how it works or why it works. So this was really nice work, because it showed that, you know, there were two elements. It's not just enough to be present, although presence is important, so 24/7 availability, but you also need people who are competent, who are present. And actually that may seem very obvious, but it's not to everybody, because sometimes, you know, if we think of the replacement with an electronic bot, then I'm not sure the bot will be as competent as we need it to be. And that's the challenge about the 24-hour care, is its presence and competence that are needed, because that gives people a security. And it's that security that enables people to remain at home, because of the presence, the availability of the services they think they can, and competence. And in some ways, that's often what palliative care is involved in doing. But it doesn't cost the health system a lot more money to do palliative care. And here's the paradox. Some really nice work by Peter May and Charles Normand and also Sean Morrison in the US showed that in hospital, if you had earlier referral to a palliative care team, you actually save money in the hospital. And interestingly, the cost saving is greater when people are referred earlier. So if you have a little bit longer with the if people are referred earlier, so if they're referred within 2 days of admission to hospital, rather than 20 days later, you get a bigger cost saving for the individuals. And that's quite important. So, you know, quite often, I don't know about you, I still do clinical work, by the way, so there I am on a Friday night. It's 5:15, I've just taken on call. I'm rung up by the hospital. We have a patient, they need to see the palliative care team. We made a referral today, but they haven't been able to see them yet. I say, oh, okay, when did you make the referral? 4:15, they say. I said, oh, okay, yeah, that might have been difficult. Let me see how I can help you. How long has she been in hospital? She came in a month ago, you know. So it's much more difficult for me to help in that circumstance. And, you know, we need systems where actually there's a little bit more timely referral to palliative care. The other interesting thing, though, that I'm going to build on here is that the cost savings are much greater when people have multiple morbidity. So actually, this is really nice data, again from Peter May, who I'm very happy to say we've managed to attract from Ireland to our group in the UK. I'm very proud of that. Peter, if you're listening, thank you. The cost savings are greater when people have multiple morbidities. So this is the 2-gay group, so the group that did the best. But if you divide people into, just very simply, no Charleston comorbidity index or anything, just do they have 2 or 3 comorbidities or 4 or more, because those are the populations that we're normally seeing now, then actually the ones with more complexity did better and had greater cost savings. So the question then is, what model do we need to try and work with these more fluctuant diseases and have palliative care integrating? And I think that we need to have some kind of system of triggering referrals and reassessment in palliative care. As we get involved earlier, how can we trigger the right sort of assessment in a fluctuating diseases? So this is a model that Matt Maddox and others have put together about how when there are dips, you might think about how there's an indication for palliative care and then the possible mechanisms for integrated working, because the integrated working between us and palliative care and individual specialists or hospitalists, I love that term, by the way, thank you, or the community services that exist will be very important. And in that, the last bit I want to come on to really is measurement. Because actually measurement in palliative care is going to be very important, particularly if we are going to influence things at scale. If we think about healthcare, all of clinical care involves some kind of measurement which helps us understand need, diagnosis, measures change, and more. So there's all the usual, physiological measures and scans and so on. Then people have moved towards assessing general health with quality of life and so on. And in our field of palliative care, we need more the sort of outcomes. And it's great that you started all that time ago the idea of doing measurement. And we, of course, have been working on something called the Integrated Palliative Care Outcome Scale. It's a very simple measure. It started off in little booklets like that teams can use. It's now integrated into the clinical record. If you're really got problems and people are allergic to the word palliative, you can call it the patient outcome scale, and somehow the P works, and so we do use that occasionally. But we can also explain palliative care. We have a website, it's free to access, which where you can download the different versions. There's opportunities for all sorts of different specialists to use it, and so on. And I think that we're now more than 114 countries. We're up to about 125 or so. So we've got an awful lot of different individuals that use it. But it's also free at the point of delivery. So it's copyrighted but free to use, which is important because we don't want people paying for the use of these measures. And if you think about that in the healthcare with the CogStack data that I showed you, actually we're looking at integrating measures such as the POS and the iPOS to develop early warning systems, decision support, and AI. We've already done a little bit of work in this that we're just refining. So if you take a question in the iPOS, which is the one about depression, then what we've developed working with experts and patients and literature reviews is if you score of 1 or a 1 or 2, what do you do? If you score a score of 2 or more, what do you do? If you score a 3 or 4, what do you do? It's not easy to develop these decision support systems, but it is quite important and helpful. And we've been building this into a system in care homes now to help the care home staff try and make assessments on individual items of the POS that they can move things forward. And I just want to remind us of how flexible palliative care is. So in the COVID pandemic, the CovPal, the palliative care responded really well. And we studied this in a project called CovPal. And we learned from the patient data that were collected across services all across the UK how palliative care had improvements in their symptoms. And we've been able to demonstrate how palliative care helped symptoms, particularly things like breathlessness, if people had time in care. And the changes were particularly marked if people had longer in care, so 4 or more days in care, but even with a couple of days in care, as you can see. So the red was before, the green is after. These are actually graphics. My friend calls them splat charts, but I prefer the term radar charts because it sounds a bit posher. But they basically show the percentages across a range of things. And so you can see the green areas are smaller, showing that even within very short periods of time, we were able to do some symptom relief. But we were able to show that and study it and understand it because we were collecting information and measuring things. And we were also able to show triggers of deterioration. So in COVID, actually, severe breathlessness is a marked trigger for rapid death. I'm sure many of you saw that clinically, but here you can see that proven with the survival charts of people with the most severe overwhelming breathless, which is the lowest level of the survival chart, and the other ones which are kind of less severe breathlessness. So, to bring it all together, first of all, I think we do need investment in palliative care. And I think there's no case for not investing in palliative care services, that's specialist palliative care services of the kind that you get. And I think there's an important opportunity to do that across all settings. And I'm going to encourage you to think about not only greater integration with many other specialists, but also greater integration with rehabilitation, because I think that's going to be important for the populations of the future. And it is an area where I've changed my mind, and I think changing your mind is always a good thing. And initially, when I was working in palliative care, I couldn't much see a role for rehabilitation because it was so end of life. But now, as we move back up the disease trajectory, it's what our patients want. And actually, some recent work that my colleague, who's an expert in rehabilitation, Matt Maddox, has been doing is showing that actually mobility is a very important concern for many people. So being able to show that sort of frailty reduction is important. It will also be important for the concept of health, maintaining people in their own homes and boosting self-care. We need to get investment in research. I don't know what percentage of the research budget in the US goes on palliative care, and perhaps somebody can tell me that. In the UK, it's so small. Does anyone want to guess how little it is? 0.1%. It's a little more than 0.1%. It's about 0.25%. Okay, but under 1%, and it doesn't make a lot. And you know, palliative care research is not necessarily as expensive as some other areas of research. It's kind of more people expensive. There are opportunities to do it more efficiently now with big data, but you'll still need trials and so on, and it needs people. But it doesn't usually or so often need big lab space, big techie machines, and so on, as you might get in other areas of research. So I think there are opportunities. And palliative care services need that because we need to advance the therapies and treatments that we're offering to make them better for our patients, to make them good for the patients with neurology, the patients with interstitial lung disease, the patients with multimorbidity. I think there's a role of palliative care and hospice in actually pioneering and doing the innovation and using the philanthropy that I mentioned at the beginning to generate new, better ways of doing things and then testing that through proper research. So take home some thoughts. I think we have a new era, a new landscape for palliative care. Not only the climate crisis, but also the aging, multimorbidity, and the fluctuating trajectories that we see. I think we have new models of palliative care, and we're already in the business of palliative care to live well and to live well also at the end of life. I think we're driving forward much more now integration, but we probably need to learn how to do that. And we've shown how in the COVID pandemic we can respond to healthcare crises. And then I think we need transformative research, and I'll add to this as well, transformative education. So we need these things for complex services, new cost-effective therapies, models of care, technologies. Clinical academic integration is going to be essential for that, and this is where you have such amazing benefits here. because we do need to recognize that it's complex, and to do it in a solely research environment will miss the complexity of the reality that affects patients, and to do it in a solely clinical environment will miss the potential advances that research methods have to look at things. Now I'm going to come back to Cicely. Steve started us nicely with Cicely. It was my privilege to know Cicely. Cicely talked about the whole person. The body and the mind was her image, and you can see it here. She kind of understood the complexity right there and then, and here it is again in front of us. And I'm going to bring us back to the individual. So we have a science, and we have a caring. And in a way, the science that we have, I think, is the science that puts the person before the diseases, the person before the individual methodologies, and that's the science that we want to do. So I think that palliative care has great opportunities to deal with really what are quite substantial challenges facing healthcare in the future. But we are a small field, so it's going to be quite hard for us to do it. We will have to focus, we'll have to work together, we'll have to support each other. I think here international collaboration and learning from each other is going to be really valuable. But we are a growing field, and we understand the future populations probably already better than anybody else does. So I think we have a role that's very important to play. And I'm going to end by saying thank you, and also thank you to my many colleagues who've helped me over the time, and my team back in the UK. So thank you very much for your attention and time.
Well, Irene, thank you so much for that brilliant walk through our field and thinking about the future. That was really wonderful. We do have some time for questions. If we have questions, I know you could, if you're on Zoom, you can put questions in the chat. I had a couple.
I wanted the 4 antibiotics, actually.
Yeah. One thing I really appreciate what you said about the kind of the physical therapy, occupational therapy, speech and language therapy. I think I totally agree with you. I think incredibly important. I think we see this, we see clinically what you saw in your studies on breathlessness, just the value of pulmonary rehab, for example. I will say that our physical therapists and occupational therapists have reached out to us to collaborate. They're really interested in doing advanced care planning and having these conversations with patients. They spend a lot of time with patients, as it turns out. They understand their functional status and really want to be engaged, or having these conversations with patients and want to learn. So I think there's both sort of the core work that they do, but also an expanded role. So I appreciate that. You mentioned about dips in trajectories and how trajectories are changing and how a dip could be a trigger. And I guess it got me thinking, is recovery then somehow a trigger that you don't need specialist palliative care, right? The challenge is that you just bring more and more people in, and they want to stay with you. They like the care, and just trying to think about how to manage workforce and demand. Do you think that, how do you think about the kind of in and out?
Okay, yeah, so one of the areas that we've been experimenting with is what we've been calling short-term palliative care. And we've done this in neurology, aging, and respiratory disease now. So the idea of short-term palliative care is that you have from the beginning, it is a fixed period of time. Or it is expected to not be open-ended. Because one of the problems is that you go to palliative care and it's an open-ended sort of thing, and you carry on. But actually, if you think about it, if you go to a cardiologist or a specialist or in any other area, you wouldn't necessarily assume that if you get a bit better, you'd stay with them. You just know you can come back. And I think that we have to take a little bit of responsibility for negotiating and presenting at the get-go, and I think we can do that. And the way it's easier for people to understand it is to say, well, actually, you're going to see somebody 3 times, and then the plan is that we'll then discharge you, but obviously we'll review that at the 3rd point in time. And in a way, you have a plan of what you do in the 3 times. So in the Breathlessness Support Service, that's exactly what we did.
Thank
Okay, we have time for one more question. I do have one online. Irene, thank you. What work are you aware of in articulating the ethics of care in healthcare and palliative care, putting the particular person and situation at the core of decision making?
Gosh, well, there is work going on in that. There's work going on in that here. There's work going on in that in various places. I'm not sure I could, off the top of my head, get all the lists of things, but I'm quite happy to try and pick that up afterwards. Thank you. And thank you for the question from the person online. It's a very good question. And I hope that they are doing something in the ethics area.
Great. Irene, thank you.
Thank you.